Welcome to today's meeting organized by JNNP in partnership with the Department of Radiology, West China Hospital, who kindly proposed this important event. My name is Karen Fury. I'm editor-in-chief of JNNP. It is a great pleasure to chair today's meeting on Alzheimer's disease and imaging. After this roundtable, JNNP plans to publish a report on the event today and possibly develop a collection of articles based on the themes and discussion points that emerged today. We are delighted to be joined by an excellent lineup of international experts, both in person here in Chengdu, as well as joining us virtually from the United Kingdom, the United States, Germany, Switzerland, and the Netherlands, who are going to share their knowledge and expertise. In the meeting today, we will have 4 scene-setting presentations on the clinical imaging of AD-related symptoms and the effectiveness of treatments, followed by 2 roundtable discussions. Today's event will be bilingual in Mandarin and English with simultaneous interpretation available both online and in person. I would now like to introduce another roundtable chairman for today's opening remarks, Professor Su Lui, Chair of the Department of Radiology, West China Hospital. Professor Lui is the winner of the Outstanding Youth Fund of National Natural Science in China and the Deputy Leader of Big Data and Scientific Research Group, Chinese Society of Radiology. Welcome.
Thank you so much for the introduction, Karen. And so first, I would like to welcome all the excellent, distinguished professors from all over the world, and especially the professors on the round table. And also, I would like to give a brief introduction of our department and our hospitals. So our hospital located in the southwest area of China, located in Chengdu. So Chengdu is a very beautiful city, very famous because of the pandas. So all the pandas from all over the world from Chengdu. And because of the pandas, we will come many peoples from all over the world. And I am here want to invite all the professors from all over the world to come to Chengdu, and I'm looking forward to meet you in person. Tonight, it is our great honor here to organize this ground tables. We are discussing is important topic about the area in the treatment of Alzheimer's disease. The new drug have been applied in China for at least half of the years. So it's quite important to have concepts about how to use imaging to guide the treatment. So tonight, we do need your support to give us many comments and suggestions about the instructions for the radiologists in the treatment of the Alzheimer's disease, and also in the evaluation, especially the imaging evaluation of area in Alzheimer's disease. So I'm here to want to thank all the professors to join this meeting, and I hope you can join the roundtable meeting. Thank you so much.
Thank you, Professor Lui. Now I'm delighted to introduce to Professor Tammy Benzinger, who is joining us from the US. Dr. Benzinger is the Hugh Monroe Wilson Professor of Radiology and Neurosurgical Surgery at Washington University School of Medicine in St. Louis, where she serves as the Medical Director for MRI Services at Mallinckrodt Institute of Radiology, St. Louis, and Barnes Jewish Hospital. Dr. Benzinger will give us the first of our presentations on ARIA in immunotherapeutic treatment of Alzheimer's disease.
Thank you so much for the introduction and for the invitation. It's very, very much an honor to be here with you today. I'm going to be talking about ARIA in immunotherapy. And here are my disclosures. I have research support from multiple entities, including the National Institutes of Health in the United States, but also collaborations with many pharma partners who are working together with us on these projects for Alzheimer's disease. For my section, I'm going to hope to set the stage for imaging in Alzheimer's disease, talking about some of the recommendations that have been developed in the United States through the American Society for Neuroradiology for imaging for ARIA, a little bit of the outline of the key findings, both for baseline MRI as well as for monitoring, and then share with you both the challenges that we've encountered in my own practice, as well as some opportunities that might be available for future research and collaboration. Just a very quick review. What we're talking about today are anti-amyloid therapies. And so these are targeting one of the two key proteins that are misfolded in Alzheimer's disease, or beta amyloid. There have been multiple different targets that have been worked on in recent years. And many of these, almost all of them, have used the amyloid PET scan as one of the ways to monitor whether the therapy is working. So the drugs, these are examples of somebody with a positive amyloid PET scan in the aducanumab trials who was treated with placebo, and you can see no change on follow-up, versus this is our participant who was also in that trial, was treated, and you can see the dramatic clearance of that abnormal protein from the brain. So the two drugs that we have in the US right now are lecanemab and donanemab. And my very quick research showed me that I think in China, you also have the same two medications available, but that will be something we can talk about in the discussions. Just a little bit more on the PET side. So there are many different amyloid PET tracers available, but there is a standardized scale that can be used for the quantification. So the Centiloid is a scale for measuring that amyloid PET. This is some data from lecanemab showing that drop in amyloid on the PET scan that you see on therapy. And then this is some data that was published out of also from lecanemab showing changes in the amyloid PET correlate with slowing of that cognitive decline. So we know amyloid PET is one of those key features. But the thing we want to talk about today is actually ARIA. And so how does that relate to this? So ARIA is amyloid-related imaging abnormality. It's been described for almost all of the drugs in this class, usually asymptomatic, but if you do have symptoms, they're nonspecific: headache, confusion, visual changes. And because of this, the labels in the United States for the 3 approved drugs that we have all include a recommendation for a baseline and serial monitoring. And it's really important for all of us working in caring for these patients to understand how important the accurate and timely interpretation of these scans are, because the detection of ARIA on the imaging really has a strong impact on clinical management. So the part that many of us, at least in the radiology side, were less familiar with was this idea that not only is amyloid in the gray matter, but also inside blood vessels. So these are just some examples of blood vessel walls with amyloid plaque. And the hypothesis is that both cerebral amyloid angiopathy and ARIA have a very similar mechanism. And that is that this plaque that's in the blood vessel walls, when it breaks down, whether it's spontaneous in CAA or by way of an antibody-mediated therapy, can result in leakage of the blood vessels, both in terms of a fluid that gives us vasogenic edema as well as hemorrhage. So what we see from clinical trials is that these episodes can be handled very well with monitoring by MRI and pauses in therapy. And this is an example from the DIAN-TU studies of just one patient followed over time in the study. And you can see the development of 2 areas of ARIA-E in this participant in the occipital and temporal lobes, which slowly resolve. And then over the same time course, but with a slight offset, a little bit delayed, you start to see the development of microhemorrhages also in those same areas. And we expect the microhemorrhages, when they occur, to persist and still be there on subsequent scans. What's very interesting is that there's growing evidence that the same areas that have the ARIA also have removal of the amyloid. If we do the PET scan, and here you can see a subtraction imaging showing that those are the areas that actually had the greatest removal for this participant of that amyloid. So the baseline MRI is very, very important for identifying the risk of future hemorrhages. And that's because if you already have many microhemorrhages, you probably already have CAA, or cerebral amyloid angiopathy. And so we need to do a careful MRI to look for that risk of future ARIA. It's also important for the radiologist to be thinking about, is the pattern on the MRI typical for Alzheimer's disease? Or are there other factors that might cause impairment, such as extensive white matter hyperintensities that might be small vessel ischemia, or multiple infarcts, or other conditions such as brain tumor, prior surgery that could put you at risk for hemorrhage during therapy. So I just want to close quickly with a couple of cases to share with you. So the first patient is a 70-year-old who was retired, had some progressive impairment, had been diagnosed with mild memory loss, but at the time presenting for potential therapy was very early Alzheimer's disease. We had a CDR, a clinical dementia rating, was 0.5, and our many mental status exam was 26 out of 30. So her diagnosis at this point was amnestic MCI, and we didn't know ApoE or amyloid status. She also had some typical comorbid conditions such as depression, prediabetes. We do brain volumetric examination for baseline, looking for overall structures. And this is just an example of our volumetric protocol. And she has, at this point, normal hippocampal volumes, which is what we expect for someone who does not have advanced Alzheimer's disease. So very early in Alzheimer's disease, we expect that baseline MRI to look essentially normal. On FLAIR, she has a few scattered white matter hyperintensities. So we grade these using the Physicus scale, and this would be Physicus grade 1. And then finally, the question of microhemorrhages. And this is where we start to get into some of the tricky part for radiology. The clinical trials used a T2 star gradient echo sequence for detection of the microhemorrhages. And if you look on this patient, we see 2 microhemorrhages in the right temporal lobe if we're using that same T2 star. If we use the SWI, however, there are 5 microhemorrhages. So this is one of the challenges that we're starting to face and when we're in clinical practice. She's also positive on her amyloid PET. And so now her diagnosis has changed. Her amnestic MCI is due to Alzheimer's disease. Her amyloid status is positive, and we did perform ApoE testing, and it was also E3, E4. This is important because the E4 genotype has increased risk for ARIA also. And so key points here is she would have been eligible for clinical trials. The guidelines in the United States say that if you have 5 microhemorrhages, that's a contraindication. So this was a challenge for us clinically, which we face every day. And so what we use is shared decision-making to discuss her risk. And despite this, she and her partner were very interested in the treatment, and her therapy was initiated. This is an outline of one of the proposed monitoring schemes. So you need to do multiple monitoring on a schedule to look for ARIA during the course of therapy. And this is the ARIA grading, which I know we're going to go over later in other talks as well in more detail, but just to remind you, there's a standard scale for grading ARIA. And there are also standard protocols which have been developed through the American Society for Neuroradiology that are available for sharing as well. And then just quickly give you the perspective on our practice. So I'm in St. Louis, Missouri. We're right in the center of the United States. Some people know us for the Gateway Arch. Other people know us for sports, for the St. Louis Cardinals baseball. We are only 6 million people over a very large land area. So over 180 square kilometers, 180,000 square kilometers. Our clinic, so our state has 120,000 people with Alzheimer's disease, and the clinic I work with has 3,500 patients a year. And so we did strategic planning for starting the therapy. And just to share with you the impact for us, for 180 patients with 1 infusion, it was 1,000 new MRI visits. So we really had to plan how to handle this new service line and how to provide the imaging close to where the patients live. So it takes hours for some of these patients to get all the way to our central hospital. And so we worked with the ASNR protocols to develop standards that could let us scan the patients closer to their homes. So very quickly, I want to wrap it up with one more case. So this is another patient who came in, retired professor with memory problems, very motivated for getting therapy, actually got a self-test for ApoE. There's something called 23andMe in the US, and was trying to participate in trials. And so you can see, although they're amnestic MCI, CDR 0.5, we know they're at high risk for ARIA. They're ApoE4, E4. Here's her baseline MRI. On this case, again, just mild white matter disease, no infarcts, and we had actually no hemorrhages or siderosis at baseline. So higher risk with the ApoE status, but was CSF positive, highly motivated. We discussed the case in our multidisciplinary conference and decided to start the therapy. She presented to the emergency department with a convulsive syncope, so fainted, and had a seizure only 4 days after the first infusion. So obviously we were very upset and worried. She had a head CT in the emergency department, which is not recommended, but very hard to avoid in the United States. Had no change on her MRI, so was not having ARIA by MRI. And it turns out this was paroxysmal AV block. She had a pacemaker placed. And so this is the next challenge for radiology is now what do we do? How do we get MRIs for these patients? So for her, we do have protocols in place for scanning pacemakers, but it meant that her imaging had to move to a new imaging center. And we faced challenges with a lot of these devices, whether it's spinal cord stimulators, conditional pacemakers, non-conditional pacemakers. And so, what are your options when this happens? You could stop treatment. You could adapt the protocol. What if it's not conditional? Can you do something high risk? Can you do something else? So these are the things we've been working with and thinking about. So just to show you examples. So this is what ARIA looks like on a head CT. You can still see the vasogenic edema and the sulcal effacement. This is ARIA on There's some very rapid, ultra-fast LOSAR protocol. So this is a LOSAR protocol, and the MRI takes 20 seconds, and you can see this dark area is the ARIA in this patient. And then this is ultra-low field MRI. You can see the vasogenic edema in this patient with ARIA. So these are just different scenarios we're working very actively on so that we can continue to treat the patients. So wrapping up with this patient has the pacemaker, does develop ARIA. You can see the edema and the microhemorrhage. Asymptomatic, so with mild ARIA E and H, we continued the therapy with close monitoring. The edema resolved, the microhemorrhage remained just as we expect, and no symptoms, and continued on therapy successfully. So very, very challenging patient population to work with. We currently have 233 on therapy. We had 32 that stopped therapy. Only 7 of these were due to ARIA, but in the real life, you have other reasons. So cancer diagnosis, anxiety, discomfort with the MRI. Working this to be successful requires very close collaborations between all of the team members in care, radiology, neurology, geriatrics, primary care, and also with nurses and infusion centers. So with that, I want to thank all of you for your attention and all of our study participants over all of the years in this area. Thank you.
Thank you, Professor Benzinger, for a very comprehensive presentation and some really compelling cases that highlight some of the challenges in this area. I will now invite Professor Yao Liu, Academic Leader of Radiology and Director of the Department of Radiology, Beijing Tuntan Hospital, Capital Medical University. Professor Liu is also the Deputy Director at the Department of Medical Imaging, Capital Medical University, and has published various high-impact articles in the area of neuroradiology. Professor Liu will present on AI-assisted radiological diagnosis of brain lesions.
Okay, thank you, Karen. Hello, Frederick. Hello, Sarah. Because Frederick is my mentor, so I need to say hello to him. Yeah, so, and Sarah is my good friend. We have lots of collaborations. First, give a very brief introduction about my hospital. My hospital is Beijing Tiantan Hospital, and Tiantan means the Temple of Heaven. So this is a sample of Beijing and of the whole China. Our hospital is a national neurological center, and which ranked the top 1 in neurology and neurosurgery. I will give a very quick, because today the topic is mainly about AI, artificial intelligence. For artificial intelligence in neurological diseases, the most used model is the CNN model till now, and the most used sequence is FLAIR. And the application mainly used in the lesion segmentation and also the classification. For the lesion detection and segmentation, the first thing is using FLAIR to segment the white matter lesions on FLAIR. And also now more and more research on FLAIR and also T1, contrast enhancement, to segment the FLAIR lesions and also the contrast enhanced lesions. This is something we are developing because white matter lesions can occur in multiple sclerosis, which is my major research focus, and also MSD, Parkinson's disease, and also some rare disease like NIID, also Alzheimer disease. So we developed a tool can segment all the white matter lesions across different diseases and without manual labeling. And also we have developed some new software to segment the spinal cord lesions, not only the spinal cord MS lesions, but also spinal cord tumors and different. And we can also use the algorithm to differentiate its artificial, it's an artifact or it's a real lesion, and then tell the lesion is a tumor or it's a inflammation lesions. The second thing, using AI, we can characterize, we can measure the neurodegeneration. This is some paper mainly used in MS and can be also used in Alzheimer disease. It's called deep gray rating by artificial intelligence. It can measure the thalamus and also the deep gray matter volumes. Also, we can also measure the progression of the regional gray matter atrophies, but this is mainly used in MS. We can use that to monitor the MS progression. And this is some studies using artificial intelligence for Alzheimer's disease, can segment the brain volumes and can also tell where is a specific location for the Alzheimer's diseases. Something is very popular. This is also many publications in JNNP, like the brain age. The first publication is in Nature Neuroscience. It said the brain age gap can reflect the neurodegeneration and can be correlated with the genetic background. This is some paper applied for MS. They found MS is elder compared to their real age, around 8 years. And the elderest is mainly in secondary progressive MS. And this is our paper published in JNNP last year. We measured the brain age in MS and also MISD. We found MS is 13 years elder and MOSD is 5 years elder. And if the patient is 20 years elder compared to their real age, they will have a very high probability to get progression. Now we have extended the brain age in different neurological diseases, including Alzheimer's disease, Parkinson's disease, and also small vessel diseases. Like Alzheimer's disease is just 6 years elder compared to their real age or their biological age. And this is some using brain age to compare between the different studies and scanners and the geography locations. It validated it can be a very simple measurement for neurodegeneration. And also, we can measure the brain age using PET, not only using the MI, can be using the PET. So the last one, well, the first part is how we use AI in clinical practice. I will talk a little bit about how to use AI for area. This is something using gray matter atrophy for differential diagnosis between different neuroinflammation diseases. And also, this is a very interesting publication this year using the artificial intelligence model to integrate MRI images and also the demographic information. Can use it for, I think use it like an AI doctor can distinguish the 10 distinct dimension etiology, like the Alzheimer's disease, Parkinson's disease, or brain trauma. This is something we are also using the AI for spinal cord to differentiate different neurological diseases. We use artificial intelligence to can differentiate different tumors and different inflammation lesions in the spinal cord. And this is some paper. Besides the differential diagnosis, we can use in the artificial intelligence now is more and more popular to predict the disease progression in MS, and also in this is also combining some biomarker together to predict the disease progression for Alzheimer's disease. Using artificial intelligence, we can do the differential diagnosis, predicting the treatment, and also we can subtyping the different diseases. This is a very interesting paper, can differentiate the MS patient as cortical lead and also normal appearing white matter lead and also the lesion lead. And the cortical lead with the highest risk of the confirmed disability progression and the highest relapse rate. This is also some our papers, how to differentiate subtyping the MS and the MOSD patients. I will talk more about the AD. For Alzheimer's disease, there are also some interesting publications to subtyping Alzheimer's disease with the limbic predominant atrophy type and also the hippocampal sparing atrophy type. The second type have a more generalized cognitive and severe impairment. And this is a little bit about the area. Because in my hospital, the new drug just launched, I think 3 months ago. There is a very long waiting list. Using this drug, I know the Chinese people are really rich because it's really, really high expensive in China, but the waiting list is really long in my hospital. But now it's a pity I don't have my case because we didn't summarize. We will routinely follow up the patients. But now there are already some people using artificial intelligence to identify the area and also classify the area E and area H. This is some paper just published in JAMA Network Open. They use artificial intelligence automatically detect, also quantified the lesions of area E and area H. The last one is some very new progress about the neurological diseases using artificial intelligence. The first one, I think, we must say is a large language model. This is something like using ChatGPT to diagnose neurological diseases, but it also have some drawback or some weakness. This is something our work. We use a large language model. We call it a drug image RAD GPT. We use that to automatically give the radiology report for head CT and head MRI. So maybe in the near future, many of the radiologists will have less job. We will enjoy our life. And this is something, the second trend for AI in neurological diseases, I think will be using the multi-omics to do the biological interpretation for the radiological findings, and also combining the radiomics and with the multi-omics. And the last one, I think the previous professor also mentioned the portable MRI. I think in the future for neurological diseases plus AI, in the future, I think the ultra low field MRI will be widely used. Maybe it can be based on the community, or maybe in the at home you can buy an MRI to monitor the area and also monitor the lesion progression. And this is something, when I come back to China, it's already 6 years. This is something I'm building. The first database is the CLUE project. It's mainly the National MS and MOSD database. And second one is the National Brain Tumor Database. We want to have 100,000 brain tumors with the multi-omics, MRI, and also the tissues and the blood tissues for protein and for metabolisms. So thank you so much for the invitation. My great pleasure to join the JNNP meeting. Thank you so much.
Thank you very much, Professor Liu, for a very interesting presentation on AI and its potential application. I will now hand the discussion over to my colleague, Professor Liu, to moderate the rest of the presentations. Thank you.
So thank you so much for the inspiring presentation. And so next I have to, host the second session because they give me Mandarin version, so I have to so I have to speak in Mandarin. Okay, but I believe someone will translate it into English. Okay.
Okay, now I'd like to invite the third speaker, Professor Frederick Barhoff. Professor Barhoff is a senior specialist in neuroradiology He is working at the Amsterdam University Medical Center Radiology and Nuclear Medical School in Netherlands, and also the Neurology Research Institute of the Queen Plaza of the UCL. And he was also chair of the Dutch Neuroradiology Society. His topic will be the radiology diagnosis area. Over to you, please.
Yes, thank you for the invitation. I hope you can hear me well. I'm in my hospital trying to do some clinical reporting, so I hope there's not too much background noise. It's a pleasure to be here. I wish I could be with you in Chengdu. The good news is that I've been there in the past. I've seen the Panda Reserve, and I like going to China, and it's good to see my former student Zhao Liu, who is doing so well in Tianchan and hospital in the room. So let me find my slides for you. Here they are. I hope you can see them.
Yes.
Let me get my pointer out. So I will talking about the radiological assessment of ARIA, building on what Professor Tammy Bensinger has already told you. Like her, I work with various companies in the MS, but also in the Alzheimer field related to drug development, and do a lot of safety readings and trials to detect ARIA. So yeah, Alzheimer's disease, of course, has been a devastating disease, but now for the first time we have a treatment that not only modifies the symptoms like the acetylcholinesterase inhibitors, but they also have something that may modify the disease by removing some of the proteins that characterize it, specifically against amyloid, but there are also antibodies being developed against tau and TRAM, which is involved in microglia activation. So there's more on the horizon, I hope. So this is an outline I would like to discuss, especially how you define ARIA. I will not go too much into pathophysiology, talk a little bit about the role of the neuroradiologist. And Tammy already mentioned a little bit how we select patients, but also how do we monitor, how do we rate the abnormalities, and what is the impact on the healthcare system, and can we deal with all these challenges? So just going back to the basics of ARIA related, and this is from an earlier study with papanosumab, one of the first antibodies, which was discontinued, but already then it was noticed that people may develop huge abnormalities like this, edematous areas that you especially on a FLAIR scan, but you also see it on a T2, of course, here in the occipital lobe. And you may think that's all, but in fact, the whole temporal lobe is abnormal. Notice there are also patches of abnormalities over here. And notice also that the normal sulcal pattern, which is preserved on the left side, the whole sulcal pattern is effaced. So the whole temporal lobe and occipital lobe are affected. So it's more extensive than you might think initially. Here's one of the first cases I saw myself, was a patient in the very early gantenerumab studies, also a product that has been discontinued. And this patient had a baseline scan here and then developed this abnormality in the right temporal lobe, again with some patchy high signal on the FLAIR, but also some effacement of the sulcal pattern around it. The drug was stopped, and then you can see it's diminishing, and on a subsequent scan, it later disappeared. So interestingly, this patient didn't have any microhemorrhages at all at baseline, but in the same exact location where the ARIA occurred, afterwards developed these microhemorrhages that you can see on the T2 star gradient echo image. This patient was in a PET study, and she was amyloid PET positive. And here's the follow-up scan, which is actually a difference map between the baseline and the follow-up. You can see that the greatest amount of amyloid reduction occurred in the area where she developed the ARIA. So probably if you remove too much amyloids too quickly, you sort of clog the drainage system and produce edema, and probably also remove the amyloid from the vessel wall, leading to vessel fragility and microhemorrhages. Here's another example from yet another study, this with papanosumab again. You can see at baseline, there's amyloid in the frontal lobes, and then you can see at follow-up that there's a clear reduction in the amyloid in these areas. But in these same abnormalities, patients in the meantime developed bright signal on the flare, which represent area E, but also abnormalities here in the occipital lobe. And then subsequently, you can see abnormalities on the gradient echo images, which are partly microhemorrhages, but partly also superficial siderosis. So as I said, in the normal circumstances, amyloid needs to be transported in the vessel wall. And for some reason, if you mobilize too much of the amyloid, it disrupts the vessel wall, leading to, on the one hand, extravasation of fluid, which causes edema. On the other hand, fragility of the vessel wall, which may then cause leakage of blood products in the perivascular spaces. So we've talked already about parenchymal hyperintensities on the flare, and we've talked about parenchymal microbleeds. Now I want to show you two other appearances of ARIA. So here you see the baseline scan at the bottom and the treatment on the top. And you can see after treatment, there's an area of bright signal that now occurs in the sulcus. So not in the parenchyma, in the sulcus. It's called an effusion. And you can also see that a dark area developed on the gradient echo image, which is called siderosis or superficial siderosis. So here's a more didactic scheme of how we define ARIA. So you can either have ARIA E or you can have ARIA H. And E stands for either edema or effusion, and H stands for hemosiderin. And this you define on a T2 star on a gradient echo image. If it's in the parenchyma, it's a microbleed. If it's in the sulcus, it's called siderosis. Whereas the E can be in the parenchyma, it's called edema, or in the sulcus, then called effusion. So this seems quite simple to recognize, but in reality, it's often quite difficult. So here's another patient who was treated with aducanumab in another study, and you can see at the baseline there's a considerable amount of bright signal already representing cerebrovascular disease, which is not uncommon in the elderly, of course. There were no microbleeds. And then at follow-up, it's actually not that easy to see, but if I point it out to you, you will notice that there's a sulcus that used to be black and is now dark. But it's not that easy to pick it up because there's a background of a bright signal occurring in the surrounding tissue. And also at follow-up, this patient developed microbleeds, but now in a different location than the ARIA E. So sometimes it coincides in the same region, sometimes it's in a different region. Here's another example of a patient with quite extensive cerebrovascular disease, which in itself is a risk factor for ARIA. So that's, as Tammy said, you need to consider whether you want to treat the patient and at least have a discussion so that the patient understands that at a higher risk to develop ARIA. And also here, an abnormality occurred mostly in a sulcal pattern, so an effusion. But obviously the detection of these abnormalities is hampered by the fact that there is pre-existing bright signal on the flare. So one approach that we've taken to try to overcome these problems is image registration and subtraction. So here you see the baseline and a follow-up image of a patient who was treated with an amyloid antibody. So there's extensive small vessel disease. It's also not the best flare. There's some bright signal in the ventricles that shouldn't be there. And I guess you would probably recognize the bright signal here in the sulci and on this side. So something is happening there. But if we now subtract the images, it's much easier to see, of course, because all the baseline abnormality disappears. And now we can see that there's in fact also an abnormality in the frontal lobes, which if you go back, you can recognize only by virtue of the fact there's a bit of effacement of the sulcal pattern. You cannot recognize the normal sulci anymore, but it's not easy to see any bright signal. So image registration and subtraction can help, and especially if nowadays we have 3D flare, it's much easier to register and subtract images than with these old images that are 2D. Is there a differential diagnosis? Well, in principle there is. If you would randomly see this and you wouldn't know the patient is on an antibody, you may think of ischemia, for example. So a diffusion scan may be useful to rule out ischemia. You might think of PRES, which is usually more symmetrical and parasagittal, but can be asymmetric. So if a patient has hypertension, for example, you might think of this. You could briefly think of an encephalitis. not very common, of course, to have such extensive abnormalities. And I think the most likely differential diagnosis is inflammatory CAA, which in fact is the same as ARIA induced by treatment and is just perhaps also related to spontaneous amyloid antibody development. Here's a case of inflammatory CAA. So at the baseline, patient had very little abnormalities on the flare, but had lots of lower microbeats on an FWI. And then at follow-up, this patient had actually multiple episodes of inflammation, sometimes with symptoms, could be with drowsiness, one time with epilepsy, but also sometimes silent episodes, a little bit like treatment-induced ARIA, which can be symptomatic, but often is asymptomatic. And you can see that there's edema developing and lots of new microbleeds developing. Perhaps also some sulcal effusion happening here, or parenchymal or sulcal, and again with the development of new cerebral microbleeds. So this spontaneous CAA-related inflammation is very similar to the drug-induced ARIA that we see. Another thing that may happen spontaneously is superficial siderosis. In a small proportion of the patients that come to our memory clinic and are diagnosed with Alzheimer's disease, we will see superficial siderosis between 3 and 5%. And obviously, that is very similar to what you can see with drug-induced ARIA-H. So I've already discussed the key findings and the radiological similarity to CAA-related inflammation. And in fact, in the appropriate setting, I don't think there's a differential diagnosis, although sometimes people may be symptomatic being brought to an emergency room without having the information that the patient is on antibody. And then you may scratch your head for a while. But in the appropriate setting, if you know the patient is treated with these drugs, then it's simple. It usually starts relatively soon after initiation, so in the first couple of months. And as already mentioned, there are various risk factors. And if you know the patient has risk factors, you can be on the lookout for these pathologies. I will briefly show you the evolution of ARIA. So this is a baseline scan. And here you see ARIA developing or at its maximum. But in fact, if you go back, it's probably happening here already. But here it was first identified, and then at follow-up, it will resolve, especially if you stop the treatment. But in trials, sometimes people have been dosed through, and also even if you continue dosing, the ARIA can resolve. We need to describe the severity of it depending on the size and on whether it's multifocal, and we can call it mild, moderate, and severe. And then the management of ARIA depends on the severity. Clinical severity, so if it's clinical symptoms, you always have to suspend or even stop the dosing. But depending on the radiological severity, you may also suspend or stop the dosing. Similarly, for ARIA-H, there are rating scales depending on the number of micro hemorrhages and the number of areas with superficial siderosis, which may lead to drug interruption or even suspension at some stage. And this will differ from drug to drug and probably even from region to region. I'm not sure the Chinese label could be different than this American label. As Tammy has mentioned, we need to do more about education. So I'm proud to be part of this working shop of the ASNR, which has now produced 2 white papers. And we're also setting up a working group in Europe between the ESNR and the EAN and doing a survey about what is known for ARIA. But we need to get the knowledge out there because it's coming our way. People are confused what protocol to use. And as Tammy said, the essential parts are a flare, 3D better than 2D, and a T2 star, not an SWI, because you will see more microbleeds than what is what you would see otherwise, and that doesn't match the recommendations from the label. So one of the big worries is, will there be an ARIA tsunami? Obviously there are lots of people in the world with AD, but in the end, modeling studies show that less than 10% will be eligible based on inclusion criteria. There will be other barriers for, think of reimbursement and insurance, etc. Nevertheless, even if it's a small fraction, will be a lot of patients, and they all need frequent MRI scans, typically at least 4, sometimes more. So it would be good to have quicker scans and also to help with the interpretation of it. And Zhao already showed that there's some AI tools coming that may help, although they will always need an overread of an expert, but that may help. So one thing that we've been working on is trying to abbreviate the MRI protocol, and we've developed a rapid acquisition protocol. I'm showing you 2 scans of the same patient without ARIA, by the way, with just small vessel disease. One is the clinical scan, takes 5 minutes, and here's the accelerated scan that we can do in under 2 minutes. Likewise, we've accelerated the SWI. So here's one is the normal scan, one is the accelerated scan. It's not easy to see the differences. Even I sometimes think that we just copied over the image, but they're really different scans. And this is the fast scan in only 1 minute 40 compared to the 4-minute scan. So we can now do the whole dementia protocol in about 6.5 minutes, which obviously is very useful for monitoring ARIA. We have building up some experience now with the rapid protocol also for ARIA detection. This was a patient who was in a trial. We picked up the ARIA on the conventional 2D flare, and then on the accelerated 3D flare, you can see it equally well, if not better. So to sum up, giving you some more structured background about what is ARIA-E and what is ARIA-H. We talked about the risk factors, which is good to be aware of. It's also good to realize that many of these cases resolve spontaneously, but it's important to recognize them early on and rate the severity to make sure that they don't become symptomatic, and you may be able to adjust the dosing. So with that, I'd like to finish, and thank you for your attention.
Thank you so much. Thank you for your kind presentation. Next, I'll welcome our last speaker from the Peking Union Medical College Hospital, the director of Department of Radiology, Dr. Feng Feng. Dr. Feng Feng, she is actually the director of the Department of Imaging and Nuclear Medicine in PUMCH. She is also the deputy chairman for Society of Radiology and Beijing Medical Association. She has many other titles, and she will present today on the clinical imaging workflow of monitoring immunotherapeutic treatment for AD patients. So let's welcome Professor Feng Feng.
Good morning, afternoon, and evening. Thank you for the introduction. I'd like to thank the organizer for providing this opportunity to share our experience on what we learned and in the course of treat the patient. So my topic is imaging protocol and workflow, especially in Peking Union Medical College Hospital. As we all know, this immunotherapy, the goal of this immunotherapy is to lower beta amyloid burden, then to slow the disease progression. For the target population, that's the work from the neurologist in our hospital. And we work together as a group. So we routinely read the cases together with the radiologists from nuclear medicine and neurologist as me in MRI, and all neurologists who dedicated to dementia clinic. So this is one of our case. The baseline examination should be include beta amyloid PET and the tau PET together. So the beta amyloid positive, and this tau just a little bit early stage positive in the medial temporal lobe. So this patient, we also performed the MRI, brain MRI with the auto segmentation and the reconstruction. We can see the atrophy in this patient only restricted to the early stage of AD, like temporal lobe and a little bit in the frontal lobe. we all know the pathogenesis of ARIA is the main risk is ApoE, E4, allele carrier, as the previous speakers also mentioned. And also this ARIA is dose dependence. And it's usually occur early in the course of the treatment, usually the early 6 months of the treatment. And 90% of those ARIA are asymptomatic. So for neuroradiologists in our department, the baseline MRI should to do the exclusion of the contraindications, as previous speaker also emphasized. And we also use the criteria from the American Society of Neuroradiology, and besides evaluate other structural brain abnormalities. Our ARIA monitoring strategy is a little bit different from the American standard. We use the 6 months MRI as the baseline to prior to initiation. And we add one thorough brain evaluation MRI like what Dr. Bachhoff just mentioned, the dementia protocol at the 28 weeks, half a year. And we also had one thorough brain examination at the end of the year. So altogether, we have 5 MRI examination during the first year of the treatment. So for the ARIA monitoring, standardized sequences is more important, as previous speaker also stated. So for ARIA, like edema and effusion, the same scanner is quite important, since different vendors, the flare sequences are quite different. So there is I will give you a case provided by American colleagues to show the difference on different vendors. But for evaluation of ARIA hemorrhage, the field strength is more important. So on the monitoring ARIA, we should, in our hospital, we use 3D isotropic acquisition T2 flare instead of 2D. Then we can do the NPR. On T2 flare, the setting of the time of inversion is crucial for the successful suppression of CSF. As Dr. Bachhoff just mentioned, the 3D flare is more helpful. It gives us non-selective inversion to suppress CSF signal better, I think. So we use that 3D. We should be aware that other conditions will affect CSF suppression. For example, if the patient under anesthesia have the inhale of oxygen, since oxygen is a little bit parametric, so magnetic, they would change the inversion time of CSF. And if the patient have previous contrast enhanced MRI, we should notice the T2 flare. There were some residual of the gadolinium-based contrast enhanced on T2 flare, so probably we will that's the pitfall for effusion. We should not recognize those as the effusion of the cell cell. This is the case by our American colleagues. They showed the baseline and the post-dosing evaluation on T2 flare. It seems that the high signal intensity, the coverage, the area is a little bit increased. However, if you see the details of the examination, you could see they're from two different scanners. So the same patient on the different scanner, T2 flare shows the different appearance. We should keep this in mind. For those to monitor area H, 3D SWI and other name from other vendors and 2D gradient echo T2 star would use in the evaluation. There are some, I think there are some controversial comment on this aspect. But one we should know, if you use T2 star, 2D T2 star, the time of echo time is very important. It's crucial to have a better T2 star weighted. So for the MR scanner of 3 Tesla, we can use TES 15 to 20 milliseconds. But if you use 1.5 Tesla, you should increase the time of echo to get better T2 star weighted image. But if you use lower field strength as 0.55T, you should be careful that T2 susceptibility effect should decrease on the low field strength. For the baseline MRI examination in non-hospital, we use 3 Tesla to avoid later, if you use 1.5, then you later evaluation use 3 Tesla, probably you would read more area H microhemorrhage. So we should report for the area monitoring, we should report MR field strength, what sequences, heme sensitive sequences you use, and you should report number of microbleeds, report the severity of cerebral small vessel disease burden, just as the STRIVE published in Neurology Lancet 2023. And you should standardize your flare acquisition. Sorry, this I didn't, it's an incomplete translation in English. For the follow-up MRI examination, you should try to use the same MR scanner, at least the same field strength MRI. We should keep all the sequences consistent with the previous one, and should avoid to use SWI instead of T2 star if you previously used 2D T2 star. And in all those clinical trials, T2 star was used. So those exclusion criteria was based on the T2 star. We should keep that in mind. And also the microhemorrhage, you should keep in mind that the diameter should be measured on those STRIVE imaging criteria for microbleed. It should be 5 millimeters. And you should see if they connect to the cortical veins or something, other vessels. That would be very important to distinguish the real microhemorrhage. All the new abnormality should be reported clearly, and you should talk with your neurologist who treat the patient. That's all our previous, just a very preliminary experience on real world clinical treatment. Thank you for your attention.
So thank you so much for the wonderful talk. Now, we, according to the schedule, have 10 minutes left for the QA time for the presenters. However, we're a little bit behind of the schedule, so we have 5 minutes to the Q&A. So if you have any questions, please. Very impressive talk. I just have a quick question because okay. Thanks. Very impressive talks. I just have a very quick question. So for the imaging assessment, typically people using GRE, SWI, and flare stuff to see the hemorrhage or bleeding. How about the blood vessels? For like the blood-brain barrier, I think that's more vulnerable to those amyloids sticky to the vessel and then leading to those consequences. So I just want to hear your opinions. Thanks.
I can comment on that one. Yeah, so there are various techniques for trying to better evaluate blood vessel integrity, whether that's a T1 approach like dynamic contrast enhancement, or potentially you could try to look at it the same way we look at perfusion with tumors, either with dynamic susceptibility contrast or arterial spin labeling. There are also people that have been trying to look at the what's interesting for this disease especially is the very early frames of an amyloid PET. If you do a dynamic scan, you can actually get an estimate of the first pass perfusion that can tell you something about the leakiness of the blood vessels through K-trans or R1. So all of those are very excellent and important ideas, but we don't have the data for it yet. So important research questions and potentially really important clinical research questions that could be captured as we start to roll out therapy.
Yeah, I agree with that, Tammy. It's very interesting to try to look at that. And as you said, the blood-brain barrier version of ASL might be good. I think we can also gain a lot by investing more time on the image registration and subtraction that I showed. Because in fact, oftentimes, the moment you recognize it, if you go back one scan earlier, there's actually already a subtle abnormality, and a subtraction technique may bring that out earlier. But that doesn't provide you new mechanistic insights, whereas the blood-brain barrier may show you some, tell you something about the mechanisms of RN.
Okay, thank you so much for the answer, and I think that need additional studies for the near futures, and then I'm looking forward for this. And I think that's the end of the presentation, and then we will move to the first round of the discussion. So please, I want to move the house to Professor Fury.
Thank you very much, Professor Louis. Now that our speakers have done a brilliant job of setting the stage for the imaging characteristics of ARIA, we wanted to delve into these topics in a bit more detail. Our first roundtable discussion will focus on opportunities and challenges in the real world for immunotherapeutic treatment of Alzheimer's disease. Our panelists today include Professor Barkov, who's already been introduced. We'd like to introduce Professor Nahu, Deputy Director of the Department of Radiology, West China Hospital, Sichuan University. Professor Fuhuao Yan, Director of the Department of Radiology, Rujin Hospital, Shanghai. Jiao Tong University School of Medicine. Professor Sven Haller, Medical Director at Hornevin Medical Imaging Center in Switzerland. Professor Bing Zhang, Director of Medical Imaging Center at Nanjing Drum Tower Hospital. And Professor Achim Gass, Department of Neurology, University Medical Center Mannheim, University of Heidelberg, who's joining us from Germany. Welcome to all of our panelists. We will ask for each online panelist to open your cameras if they're not already activated. And we'd like each of the panelists to weigh in on several questions. The first question for our roundtable discussion, although this has come up in the introductory talks, I'd like to really synthesize the state-of-the-art radiological and imaging techniques used to monitor the progression of Alzheimer's disease and how they should be integrated into immunotherapeutic treatment plans. Who would like to start? Maybe we can start with MRI. Would anyone like to talk about MRI in the diagnosis and follow-up after immunomodulatory therapy?
I'll be happy to kick off briefly just to get the ball rolling. So there's various elements have been mentioned already. I think probably the most important thing is education. People need to be educated about the fact that there are in-exclusion criteria and that there are safety effects, and that you need to be aware of, who's eligible, who isn't, and what safety effects can occur, and how it needs to be reported, using accepted rating scales, and what are the thresholds for those adjustments, and that you communicate them appropriately and quick enough. And then there's a series of other more logistical barriers in terms of, think of all the people who would like to be screened for these drugs. Even if in the end only 5 or 10% is eligible, means you may need to screen out the other 80 or 90%. So will be more people coming for sort of diagnostic or, eligibility scans, but then also people who go on to treatment need all the monitoring scans. So you need to schedule all these, you need to find the time slots. And that's why we've been working on accelerated protocols, and other people showed also alternative, cheaper imaging methods to accommodate for this. And then finally, you need to work first to read all these scans, which, requires, again, training and can perhaps be facilitated by AI tools that are being developed to support the detection, and things like the image registration and subtraction I mentioned may also come in handy. So these are my 5 cents.
Thank you very much. Professor Hu, do you have any thoughts on this?
Yes, thank you for the introduction, and thank you for every professor here to share your opinion with the imaging of ARIA. And the MRI emergence as the preferred modality for safety monitoring for the disease progression, especially related to the treatment-related complications. But I have some question about the T2 star brain echo sequence versus SWI. And as everybody knows, T2 star brain echo sequence has been used in the initial assessment for the patient enrollment, and it also has been recommended in many white papers to require the routine follow-up for the patients. But in China, actually, in many hospitals, in China, we use SWI rather than T2 star sequence. So I think that might be a tricky or a challenge to follow another, maybe a little different from the white paper from United States. How can we adjust, or how can we make a new decision on the SWI images rather than the T2 star images? And right now, the incidence of ARIA in our hospital is much lower than the reported data from the United States. And there might be two reasons. One is the population, the racial difference from the white people, and another might be that might be the imaging protocols, because we use SWI, which is more sensitive compared to T2 star grade GRE sequence. So we usually count more microbleeds than those becoming on the T2 star images. So maybe we have a stricter enrollment criteria rather than the recommended one. So we have the lower incidence. So I think the future, I raised the question, should we, for this roundtable here, we continue to recommend T2 star grading echo sequences, or should we not change or just consider it again, depending on the real situation or the real clinical scenarios that we used in the local hospitals. For example, we might differentiate from the hospital in China, the hospital in Japan, and also the hospital in the Europe or United States. I think the quality center, the imaging quality center of the domestic guidelines or concerts, experts cancers can be made in the specific countries or regions, depends on the usually used protocols they used. So that's my opinion. Thank you.
So what do people think about that? T2 star versus SWI. Do you think it would be problematic to use SWI at baseline and for follow-up?
I can speak a little to that. One difference is it's not just the imaging sequence you're using, but SWI usually employs a much higher spatial resolution, and that automatically increases your sensitivity to small objects. So when you put both images next to each other, so they don't show basically anything different, but maybe with more clarity, partly due to the higher resolution and partly due to the slightly enhanced susceptibility effects. However, as Frederick already alluded to, all the data that we are looking at in terms of safety and surveillance is rather based on T2 star weighted imaging, and that has been our basically our guidance, and all the numbers that we are using for inclusion, for safety, and also when rating ARIA is based on this. So we would have to re-evaluate all of that if we want to switch to SWI, but I don't think it should be a big problem, because in reality the differences are not major as long as you are trained and become familiar with the two sequence techniques. I think they both serve very well to the purpose that we are following. However, when you look at the sensitivity, you may also question, why do we use for study inclusion the magic limit of 4 microbleeds? And many of the inclusion criteria in clinical trials are based rather on historic criteria rather than scientific data. So I think this is a great opportunity now as we see real life data that we reevaluate those safety inclusion measures that we usually have employed in trials. And does not only include microbleeds, but it goes beyond. So this is one of the things that we really can address now to make it possibly available to more people, but also more safely to those who will stick out as possibly developing complications.
Thank you. Dr. Haller, you had your hand up? Lost him.
Lost.
Okay. Let me ask another question. We saw at least one example where it appeared that PET imaging predicted the area that would ultimately go on to develop ARIA. I wonder if anybody on our panel thinks that PET imaging should be part of that follow-up monitoring of patients who start on therapy.
Well, yeah. Shall I give a try first, Tammy, and then you chip in? I think, you have to prove amyloid abnormalities before you embark on these therapies. And it makes no sense to have a clinical diagnosis of Alzheimer's disease, which is wrong in 20% of the cases, without confirmation that there's amyloid pathology. But you can now do that, with alternative measures. There are definitely very reliable CSF assays for amyloid. They're developing assays in blood for amyloid, and there's also certain phospho-tau species like p-tau217 that are reasonable predictors of amyloid positivity. That's one thing. The other thing is I don't think that the amount and the distribution of amyloid itself will predict whether somebody will develop ARIA, because some people with a relatively low centiloid value may develop ARIA, and others with a very high centiloid value may not. Because the images that both Tammy and I showed are mostly looking at where the changes in that occur, and that is difficult to predict. But there are treatments where people follow what happens with the amyloid burden, and if it goes below a certain threshold, a centiloid threshold, and basically becomes a normal scan, you then stop the dosing. So there may be a reason to do PET imaging at baseline and at follow-up, just to monitor how effective the therapy is and whether or not you need to continue dosing or can stop the dosing. Tammy, you want to add to this?
Now that's exactly how I review the literature and our experience as well, is that the amyloid PET, yes, it predicts ARIA, but that's because it shows you have it in a way that you could say, oh, this person's at higher risk for ARIA. Right now, the risk factors we know for ARIA from the clinical trials are the number of baseline microhemorrhages on the GRE T2 star and the APOE4 status are the most important. But we would love to have new imaging sequences or AI or other solutions to better predict it. This is really an unmet need.
Yeah, and I think perhaps to add to that list is superficial siderosis, isn't it? That becomes more and more clear that even one area of superficial siderosis puts you at high risk for ARIA, much more than a microbleed.
Several speakers alluded to the challenges of educating radiologists broadly to be aware of the type of study that should be ordered for patients who are at risk for ARIA, and the issue of ensuring that there's follow-up on the same type of platform, same manufacturer, same field strength, same sequences in countries where patients may go to other hospitals with their symptoms. And there's no really consistent way of tracking patients so that the information about their therapies and their previous scans can move with them. Can you speak to some of the details of those challenges and perhaps provide some solutions that have percolated up in your discussions?
Yeah, the issue of multiple scanners is super interesting. There was at the CTAD recently, the CTAD Congress in Madrid, there was some first real world experiences. And somebody from New York City, where you think they would be pretty organized, presented a series of 120 cases. And these 120 patients went to 40 different scanners. And not only, I can only assume that not only did they go to 40 different scanners, but also one patient may end up on different scanners on different occasions. So this is really troublesome, of course. So the more important, I think, the efforts from the ASNR and the ESNR to try to educate people, provide protocols so that people can have a standardized protocol in place so that even in the event that you would go to a different scanner, you would be able to get a comparable sequence. But this is a major also, in the places where I work, we have multiple scanners, and I cannot guarantee that a person will end up on the same scanner the next appointment. Sven, you're
Yeah.
I wanted to shift the discussion a little bit because we have discussed a lot about ARIA and so on. But in the three papers that have been published, it is quite striking that you have a high number of ARIA patients in the placebo group. Between one half and 1/3 of patients in the placebo group also have ARIA. And this is something that I never understood, because before the introduction of these treatments, I never reported an ARIA or a PRES in a patient of dementia before. And the second question that arises now, if we know that 1 out of 3 placebo patients has, one of 3 cases of ARIA, or third, how to formulate it, in patients under placebo, ARIA can happen in a third of the cases. How can we know that the ARIA that we report is actually related to the treatment and not something else? That is if you're talking about education and so on, I think that must also be very clearly educated to those people who read scan.
Thank you. Dr. Zhang, do you have thoughts about this?
Yeah, this topic is opportunity and the challenges of the radiological service for the immunotherapeutic treatment for Alzheimer's disease in the real world. Yeah, the previous speakers discussed many standard imaging methods, sequence choice for monitoring the AD therapy. I think both speakers already mentioned a lot of challenges, such as different field trends during the follow-up, different hospital, different time, a lot of. But I'd like to say something about the opportunity. Because I think because it is a challenge, so we have opportunity. And also because the AD immunotherapy is highly rely on the imaging follow-up. So I think as a radiologist, it is our time. We are more important. So I'm very happy to have this very important role in this AD treatment. So I'd like to see some opportunity. I think there is 3 points for the opportunity in the future. The first, that's the time we can apply for the super high field MRI and also the PET MRI. Because we know in China, we have 5T already. Also in my hospital, we have one 5T last week. So I think on the 5T, we can see more microbleeding or some very subtle changes of the brain. And the previous speakers mentioned her case found there is 2 microbleed on 1.5T, but find 5 microbleeds on 3T. So that means we can find more microbleeds, microstructure changes on the higher field strength scanners. So on the 5T, we may find more and more. So in that way, how to understand the exclusion criteria, because we know the exclusion criteria for the treatment is about if there is 5 microhemorrhage, will exclude for the treatment. So how to understand that criteria on different field strengths. So maybe one may use 5T or 7T to find these microbleeds. Maybe we can change the criteria, the treatment criteria. So I think the 5T is the chance in the future to see more we can change the treatment criteria. The second point is about we can integrating and developing advanced imaging modalities. Such as we are using T2 star, SWI, and also QSM. So this kind of new sequence we can use more, maybe find more useful in this assessment. And also because I major in the functional MRI, but I know this kind of functional MRI is also used in the study, in the research, not in the clinical routine scanning. But I don't know, maybe in the future we can find some use of this kind of functional MRI, such as I major in olfactory functional MRI, and I just using this olfactory functional MRI to find the order-induced functional integration of the adrenal cortex circuit in patients with diabetes recovered after the drug, after the treatment. So I don't know, maybe the AD immuno treatment can use some this kind of new methods. The 3 point is about the integration with artificial intelligence method. Because we already discussed there is a different findings between the 1.5T, 3T scanners to find the microbleedings. Maybe in the future we can integration with AI to have the similar sensitivity finding these micro bleedings using different field trends, maybe in the future. And so the AI maybe can help us to eliminate the impact of different field trends, different hospitals, different centers in the MRI follow-up. So I think I would like to see this opportunity. We have a lot of work to do. Thank you very much.
Thank you very much. Professor Yan, can you give us your final thoughts on challenges and opportunities and close out our roundtable discussion for now?
Hello, this is Nan He from Regional Hospital. So I've been from here available, and I'm speaking representing Professor Fu Huaye. So our hospital, regional hospital, the HANA branch located in the Boer-Lochen International Medical Tourism Pilot Zone started treating the 18 patients with lecanemab on December 20th, 2023, before its official approval in China. And these 93 patients represent the earliest cohort in China to receive this treatment. So far, 247 MR scans in total were performed. And I totally agree with what Professor Huna just commented, that the SWI sequence is very critical in the baseline assessment and in the follow-up imaging assessment. So our flowchart is very similar to what they have been doing in Huaxi Hospital. We used T1 with images, T2 flare, diffusion, hippocampal coronal flare, and SWI sequence. This set of MR sequences as a protocol for all the baseline and follow-up MR exams, for every patient on the same scanner. And from this cohort, we reported very low incidence of the LAE and LH. The LAE is only 10% and LH even lower, 3.3%, which is much lower than reported in publications. So, and even more, all these patients have no symptom, are with asymptomatic and no symptoms. Basically, we are trying to figure out why is this the case. One thing we can think about is at the very beginning, everybody was very careful to use this medicine. So they performed a very strict recruitment criteria. And from these patients recruited, there is a very low level or rates of the ApoE4, E4 carriers. And another thing I would like to still go back to stabilized sequence. From my knowledge, most of the academic or research publications doing the microblading automatic detecting, those projects are based on the stabilized sequence, not on the T2 star weighted sequence. Basically, the T2 star weighted sequence of the magnitude images we can see when we do the stabilized scanning. And my own experience, since our group has been focused on the QSM, the iron deposition for the Parkinson's disease for decades. So I think I have pretty quite a few experience on this area. And in many occasions, those subtle microblades are very easy to ignore on the magnitude images, but very obvious on the stabilized images. So I think this is something we need to think about. For the challenges, besides the standardization, besides those the radiologist expertise, I would like to add another one. It's the patient cooperation. For some patients, it's a really challenge. And if somebody who's taking care of this patient is also not very aware of the scanning and not very cooperative, then it's a challenge to the operator how to perform the scan and get make sure the high quality images so we can get from this patient. Yeah, that's all.
Thank you very much. Professor Barkov, did you have a comment? I saw your hand up.
No, that was related to a previous comment from Sven about the high occurrence of ARIA in the placebo arms. I think actually, if I understood it well, Sven, but I think in most of the reported studies, it's between 1% and 3%. So it's actually a low percentage, but it happens. And some ARIA cases are subtle, of course, and there must be, could be either some spontaneous CAA. But my interpretation would be that they're just false positive reads due to artifacts or small vessel disease pathologies arising. But it signifies there is some amount of confusion and a potential false positive reads.
All right. I want to thank all of our roundtable participants for a very dynamic discussion. I think we've really moved this forward considerably.